So I'll be looking at the importance of preventive cardiology in the current era. This is again a funded talk and it's supported by AstraZeneca. So one question is, why is this topic being discussed? Because what we discuss generally, most of these meetings is about secondary prevention. We discuss about how we can prevent cardiovascular disease in people with diabetes, or how can we reduce heart failure, things like that. So this talk is just looking at how can we look at preventive cardiology in total. And thanks AstraZeneca for asking an endocrinologist to speak on this topic. So if you look at the global trends in cardiovascular disease, you can see that the age standardized cardiovascular disease rate is reducing over a period of years. When you say age standardized cardiovascular rate, I'm not a statistician, but generally what I understood is that people all over the countries all over the world differ in terms of their age constitution and disease age constitution. That means how many people of a certain age is their population. So they have something called an age standardization to look at cardiovascular disease and various other chronic diseases. All the new technologies and all the new drugs that we have been able to reduce the overall cardiovascular disease, the cardiovascular disease rate in their populations. But you look at the absolute number of deaths due to cardiovascular disease. So these are actual numbers. That is what you can see. This is per 100,000 population. This is the death in millions. The second picture. You can see the death still continues to increase. You have an aging population. You have a population which has got much increased risk of risk factors like hypertension or dyslipidemia or obesity or smoking in the community. So overall the death of people with cardiovascular disease is increasing worldwide. Now if we look at the probability of dying prematurely, that is people between 30 to 70 years of age dying because of any disease, that means unlike their age-related risk of death, cardiovascular disease will still stand as the number one cause of premature mortality among all the non-communicable diseases in the world. This is very important because you are losing a significant number of people who are productive in your community, and this can lead on to economic problems. And if you look at the cost of healthcare delivery to these people, again this is going to increase over a period of time because you are losing people who are productive and you are spending money on those people to take care of their healthcare needs. But always there is some good news to that. So this is a Swedish registry data. I'm not going into too much detail of that. But there are multiple risk factors being looked at in this population because I think one of the speakers earlier told that Sweden is good in keeping data registries. So this is again a registry data. So if you look at 5 risk factors: elevated HbA1c, elevated LDL cholesterol, albuminuria, smoking, and elevated blood pressure. If you control all the risk factors, so if you control all the 5 risk factors, you have, or if you rather not control the risk factors, you have an increased risk of death. And the more the risk factors you control here, the risk of mortality comes down, excess mortality comes down. So that means that there are risk factors, and all these risk factors are things which we can control, and it has been scientifically proven that control of these risk factors can reduce mortality in population. Now this is an emerging, or rather an emerged branch of cardiology, broad cardiology area, looking at how a patient-centered approach where a team of clinicians and or non-clinicians can assess the cardiovascular risk and implement a comprehensive strategy of risk mitigation to prevent cardiovascular disease and sequelae. So if you have a mobile which has got a QR code, just keep it ready for one QR code scanning. I'll come to that. So this is what preventive cardiology requires you to do: understanding cardiovascular anatomy and physiology, rehabilitation, ethnic and group-specific risk factors, genetics, pharmacotherapy, metabolism, imaging, and lifestyle management. So lifestyle management, Srijit has already covered. So similar things, these are all the aspects of preventive cardiology. Now coming to the scope of preventive cardiology, you can have secondary prevention. That means if you already have a first myocardial infarction, you can have methods to prevent the next myocardial infarction. Primary prevention, when you have risk factors like dyslipidemia, hypertension, or albuminuria, or smoking, you can adopt measures to prevent the first clinical event, the first myocardial infarction, the first stroke. You can prevent that. Primordial prevention stands for various other places where you can sort of interfere and lead on to improvements in primary and secondary care, or rather occurrence of a disease or a risk factor. It is more clearly seen here in this Lancet paper, where what I have marked in the column on top is what we can do in a clinic. Risk factors, we can control hypertension, dyslipidemia and diabetes. Or whenever the patient has got an acute event, we can control the patient. An acute MI can be managed early so that the person does not go into heart failure. But what is below that is also very important, as communities and as countries looking at, which are developing and looking at how to manage their huge healthcare burden. It's also important to look at how education can be done for people, how healthcare financing can be done, whether we can have legislative measures to control smoking, use of trans fats, healthy eating in schools, or you can also look at the social determinants of health, such as poverty, illiteracy, etc., urbanization, which can lead on to cardiovascular disease. So there are various areas where preventive cardiology comes from. I'm not going into too much details on this. This is the Framingham heart study, which shows that 1, 2, 3, 4, 5, 6 risk factors: cigarette smoking, high blood pressure, high cholesterol, obesity, physical inactivity and type 2 diabetes are risk factors which are associated with cardiovascular disease in a very large cohort of patients followed over a large period of time. That is the Framingham heart study. Again, I'm not going into too much of detail. We are discussing this again and again. Various ways in which a person can develop cardiovascular disease and what are the various aspects of this. Very important to look at. One is inflammation, which is a very important part of cardiovascular disease. Now we know that insulin resistance by itself is an inflammatory state leading on to cardiovascular disease. And if you look at any of the Western guidelines, they always look at cardiovascular risk calculators, and it is recommended that you can use a cardiovascular risk calculator in your outpatient department to see whether a person with no large risk factors, like is not a diabetic person with diabetes or a familial hypercholesterolemia, whether you want to start statin for that person, or whether you want to put a patient on an antihypertensive drug even with a mild hypertension. Things like this can be decided based on a cardiovascular risk calculator. There are various risk calculators. You can go online. First, most important is the Framingham risk score. Used to be very commonly used. Then we have the ASCVD risk calculators, the ADA, American College of Cardiology. Everyone recommends the ASCVD risk calculator. Again, you can go online. You can go to this calculator, put your age, sex, etc. there, and you can see your 10-year risk of developing a cardiovascular disease. One other common risk factor scoring is Q-risk-3. Again, this is used from the UK. Basically, these are all slightly ethnic specific because they have been studied only in certain countries. Q-risk is one of the studies where some amount of Indian patients have been there in the cohort of patients getting studied, and also some small data from India based on people who already suffered a heart attack, going back and seeing whether there is an increased risk of how the risk factors behave. This is the Q-risk area. So this is a QR code in case I'll pause for 10 seconds, 20 seconds here. So you can just scan this QR code. Or you can just type Q-risk-3 in the Google also. So that will take you through a risk scoring system. So in the risk scoring system, you can enter your age, HDL level, all those parameters, and then get a score. Now, coming to cardiovascular risk or disease prevention, one important thing to realize is that a person who reaches end-stage cardiovascular disease, or for that matter, end-stage renal disease, will go through a stage of cardiovascular risk factors, that is having dyslipidemia, hypertension, or smoking, or sedentary lifestyle, to a stage of developing subclinical and detectable target organ damage. That means you see a peripheral vascular disease on screening, but the patient is asymptomatic, or a carotid plaque on screening and the patient is asymptomatic. That is a subclinical heart disease, or edema media thickness if you can measure with some method. So these are all subclinical. From there, they progress on to a stage of clinical events, developing a heart attack, a stroke, things like that. And then again going into a stage of end-stage CVD, that means developing heart failure and bedridden, and then on to mortality. So these are all stages where at every stage you can have an intervention to prevent the person from going on to the next stage. This is a very confusing slide, but again, this is again trying to highlight. I'll divide the slide again to show you much more clear how things are done. So this is the American College of Cardiology 2019 guidelines on managing statin therapies and all those things and risk factors. So just to break up that chart into a small chart here. So in primary prevention, you need to look at cardiovascular disease risk in each age group. So 0 to 90, 20 to 39, 40 to 75. So 0 to 90 is a very low risk unless you have a familial hypercholesterolemia syndrome. Then anyway you need to start on statins at even at that age. 20 to 39 years, at that age it is always good to look at an ASCVD risk calculator which I just showed you. Any of the risk calculators can be done. Then use an ASCVD risk calculator, that is the second calculator that I showed. And consider statin if the family history of premenstrual atherosclerotic vascular disease is there, or LDL is more than 160 in that age group. 40 to 75 years, if your LDL is more than 70 and less than 190 without diabetes, again you can look at a 10-year risk score using that calculator to decide whether you need statin therapy or not. There are various ASCVD risk enhancers there. So if you have, even if you do everything like this and you have a risk enhancer, that makes you at a higher risk. One important condition that which we usually ignore is that one is inflammatory diseases. So someone with rheumatoid arthritis in fact has got a very high cardiovascular risk, which we don't realize. We treat people with diabetes but not with rheumatoid arthritis with statins. They have an increased cardiovascular risk. Or someone with obesity and satisfying criteria for metabolic syndrome. Now how do you manage this? This again, Srijit has already explained about healthy diet. They follow the classical things. Although they say emphasis on whole grains, Srijit will not agree to that, I suppose. This is the ADA classification. I'm not going to the AAC classification. I'm not going to contest that. But these are the general principles to be followed. Physical activity, lot of benefits in terms of psychological, anti-arrhythmic, anti-thrombotic, anti-atherosclerotic, anti-ischemic benefits. Again, very important part of dealing with cardiovascular risk. Now coming to lipid management. So 40 to 75 years of age, LDL between 70 to 190, and without diabetes, then you look at the cardiovascular risk based on the calculator. Less than 5% risk, you don't need to start on any medicine, statins for that person. You can discuss the lifestyle interventions. 5 to 7.5% risk. Look at the risk enhancers which I showed you earlier. Any of this ASCVD risk enhancers are there, then you should consider moderate intensity statin. 7.5 to 20% intermediate risk category. If the risk estimate and risk enhancers favor statin, initiate moderate intensity statin. And more than 20% is high risk, initiate statins for this patient with an LDL reduction of less than 20, more than 50%. Now, if you are uncertain on what to do, they recommend doing a calcium scoring, coronary calcium scoring, to make the decision on whether the patient falls on this side of the risk spectrum or on the higher side of the risk spectrum. But if you reach this category, which most of us treat patients with LDL more than 190, there is no risk assessment in that patient, high intensity statin. Diabetes and age between 40 to 75, moderate intensity statin. Diabetes and age between 40 to 75, consider risk assessment. That means if you have a risk enhancer or a calcium scoring which is high, go for high intensity statin. More than 75 years, discuss the risk factors and consider whether statin is going to be useful or not useful for that patient. More recommendations now is in favor of starting statin for this patient. Again, I'm not going to explain this. What is high intensity, what is moderate intensity, and what is low intensity statin. Rosuvastatin at 20 to 40 is high. Atoro at 40 to 80 is high. And moderate intensity is rosuvastatin at 5 to 10 and atorvastatin at 10 to 20. Now, as I told you, there are various studies of looking at lipid management in people with primary prevention. And Jupiter study is one of those studies where people who don't fit into the traditional criteria of risk management as defined by this criteria, that means LDL less than 130, were randomized to receive rosuvastatin versus a placebo And you can see that these patients had a 44% reduction in primary and endpoint of all vascular events. And one of the important things in this data set is that they looked at HSCRP also as an inclusion criteria. So basically trying to look at whether people who don't fit into the traditional risk category but having an HSCRP positive, do they benefit from treatment? As I told you, HSCRP is a risk enhancer or to make a decision process in that. Now again, chronic inflammatory conditions, as I told you, is an important risk factor, and you should consider that in the back of your mind when you consider statin therapy in patients. Now coming to hypertension, again I'll rush through it just to show you that this is the 2019 guidelines. Normal blood pressure 120/80, lifestyle habits 120 to 129 and less than 80, non-pharmacological therapy. Stage 1 hypertension 130 to 139, 80 to 89. Again you go for the risk scoring system, as I told you, and the risk scoring system can be used to decide your pharmacological therapy versus non-pharmacological therapy. And stage 2 hypertension, pharmacological therapy is recommended. Now, which pharmacological therapy to choose? Again, all these guidelines have different sort of recommendations. This is the 2023 European Society of Hypertension guideline. So here they have considered ACE inhibitor or ARB, calcium channel blockers, beta blockers, and the diuretics as the 5 drugs. ACE inhibitor and ARB as separate drugs, 5 drugs which can be used as the first line agents to be started in people with hypertension. A bit different from the other guidelines is the use of beta blocker as the first line agent in people with hypertension. 2023 guidelines has put this as the first line agent. And there are certain areas where there is a compelling need for the use of beta blockers. And these are the conditions whenever you have a coronary artery disease or when you have any signs of heart failure, atrial fibrillation. And I think hypertension disorders in pregnancy specifically for dimethanol. So different criteria which they have put as the 2023 guidelines for use of beta blockers. Diabetes, again I'm not going, the entire meeting is on diabetes. So 2 things to just tell you. One is use of GLP-1 RAs, specific drugs for in preventive cardiology to reduce the risk of coronary artery disease or other stroke or atherosclerotic vascular disease, and SGLT inhibitors which have a very broad area of action in terms of cardiovascular disease. Trials to support that. One is the CKD, as I told you, it's a risk enhancer. Use of SGLT inhibitors like dapagliflozin can help in terms of reducing the risk of progression of chronic kidney disease. We discussed about finerenone in the last talk. And the use of antiplatelet drugs. Again, this is the circulation 2019, that's the ACC recommendation. Low dose aspirin might be considered for the primary prevention of ASCVD. Among select, a very important part of management. And weight management is again very important. Just like Srijit has told, there is good enough data to support that weight loss can reduce cardiovascular disease. So weight management is also very important. So to sum up, we have an area where we concentrate on people who have already developed symptoms, already developed risk factors. It's important that we look at people with risk factors or primordial prevention also, manage the risk factors and treat the patients appropriately whenever they have the risk factor. Thank you very much.
Thank you.